Yes, we can see it very clearly.
Okay. And the mouse pointer also?
Yes, we could
Right,
appreciate that.
right. Thank you. Thank you. Good afternoon. So tuberculosis in children, challenges in diagnosis. We have many practical issues in the diagnosis of TB in children. Before that, as we all know, tuberculosis, the caused by Mycobacterium tuberculosis, is considered as one of the world's oldest and most formidable human pathogens. And there are some evidence with some old archaeological sites have recovered Mycobacterium tuberculosis. That means it is coexisting with humans over 15,000 years. And we have the first evidence of the confirmatory evidence of TB infection, and especially in children, in Egyptian mummies. They have recovered one child mummy. It's a around 14-year-old child with evidence of classical post disease in his spine, and they have recovered Mycobacterium tuberculosis, genetically confirmed with PCR techniques. And the specimen was dated 3400 BC. That means 5400 years ago. So that TB is going on with patients, human as well as is affecting children also since many millennia. So this disease, the pathogen has identified by Robert Koch in 1882, and since that, even now 140 years after discovering the pathogen, but still TB is a leading cause of death. And especially it was the leading cause of death from a single infectious agent before the COVID-19 pandemic. Obviously, COVID-19 became the first place, but still TB is a major cause. At least it's a second cause. It's more than HIV/AIDS infection. Estimates of WHO suggests 7.5 million children are infected with TB worldwide in 2019. And out of that, 1.2 million children actually reported to have the disease, as well as 230,000 children died of TB during 2019. Usually annually, around this figure, the children died around this amount. And out of this, that's an important thing, 80% of children who died of TB are less than 5 years of age. That's a main concern about childhood TB. Especially, it's difficult to diagnose or confirm the diagnosis in this age group. If we consider the actual number of patients treated in over last few years, according to WHO data, you can see this is the total number of the patients, and the blue to green color bar indicates the adults over 15 years who have been treated as TB, and this red color indicate the children age under 15. So the global situation is around 11% of all patients with TB, it's due to represented by the children. And out of those, almost half less than 1 year old. But the issue is still, according to WHO estimates, there's a significant proportion of children worldwide who have TB disease, but still underdiagnosed. The figures are alarming. Less than 5 years, almost 2/3 of children infected with TB are not diagnosed or not reporting properly. And 5 to 14 years in the other children age group, almost 50, almost half are not diagnosed. And adult populations, almost 1/4 of them are not being diagnosed or reported properly. So there is definite diagnostic gap. What's the situation in Sri Lanka? Usually in Sri Lanka, around 300 of children are confirmed or they're starting treatment as tuberculosis, and that is about 3% of the total number of cases considering the adult population. So the world situation is around 11% of children are there, and compared to the total number of out of the total number of cases. But Sri Lanka is around 3%, and during this COVID period, it has further reduced to less than 200, and it's around 3%. So we don't know what is the exact actual figure in Sri Lanka, but according to WHO estimate, at least 5% of the cases of the total number of cases diagnosed in Sri Lanka should be children. And these are the estimated numbers to be more than, or it's reaching 400, but usually we are seen around 200, especially during last few 2 years due to COVID-19 pandemic, some underreporting also there. So there are different challenges in the diagnosis, especially undiagnosed children and unreported children are there, even in our community, our setup. Why is that? There are important differences between when we usually consider TB, the classic picture usually we see in adult patients, but when we consider children, there are important differences. That is one of the main reasons with this underreporting, as well as there are many challenges in the diagnosis of TB in children. One thing is that the presentation, clinical presentation is highly variable. And other thing is the typical symptoms. Usually TB, the usual symptoms we coming into our mind is fever for more than 2 weeks, cough, loss of weight, and loss of appetite. But this is usually seen in adults with pulmonary TB, but not in children. Other important thing is children more likely to have TB disease following infections. I will show you figures. Another thing is more extrapulmonary involvement, especially TB lymphadenopathy in children. And the dangerous thing is they are more likely to have disseminated disease and TB meningitis, especially the vulnerable group is children less than 5 years of age. Actually, what is happening when we expose to TB bacilli, or as you all know, it's coming usually through the respiratory route, through the environment, especially containing some bacilli containing the droplets particles. But actually, 70% of the time, even though we inhale this TB bacilli, 70% of the time, we do not get an infection, even an infection. We are not infected because there are a lot of alveolar macrophages, pulmonary alveolar macrophages. Those are part of innate immune system. They then and they are clear these TB bacilli which enter into the lungs. And out of those, 30% develop infection. And even though develop infections, the disease manifestations happen in 5 to 10% of all the children and adults. The small children less than 5 years situation is different. I'll show the figures. Only few, about 5 to 10%, the disease progresses into the active TB. So the most of the time it's the progressive primary disease. The primary disease directly progress to the active disease, and that is usually happen within first 2 years of getting the acquiring the infection. 90% of the time they develop the disease within 2 years of acquiring the infections, and out of these 90%, further 90% develop the disease within the first year of the infection acquiring. Actually, if we want to get the contact history of TB, especially children, the most relevant contact history should be within last 2 years. 90% of time it's contained, and the disease might be there, or sorry, not the disease, the organisms might be there, but sometimes might be completely cleared. So that is called the latent TB or the TB infection. Sometimes they can be reactivated, then causing the post-primary TB. So this is the usual natural history of TB. The danger situation is, so this graph, this table indicate the age. Children less than 1 year of age, the no disease 50%. These figures are little changing, but this is a rough idea to get some rough idea. So they can have pulmonary disease. That means disease can be progressed to develop the disease 30 to 40% pulmonary disease, and other manifestations also for 50%. That the totally less than 1 year, 50% of children can develop the disease following infections. This is completely different to the situation in adults. So only 10% of them can develop the disease or progressions. But other problem is disseminated disease of TB meningitis less than 1 year, up to 20% of them can develop the disseminated disease, but older children and adults it's just 0.5%. So that is why we are very particular about the BCG, because the risk of dissemination is very high, less than 5 years of age, but after 5 years it's about 0.5% of the total number of cases. This graph again indicate the same thing, better visualization. This line indicate the total incidence according to the age. You can see these are the age from 0 to 20. Initial stage, small children less than 5 years, the incidence is high relatively, and then it gets little decreased. And again, when they are going older, adolescents, the disease prevalence is high. This age, the prevalence is high because of that. Just I show the chance of getting or the progression to disease is high. But here it's mainly due to increased exposure because they are more active or more dealing with the more exposure to the community. And this blue bar indicate lymph node disease and red bar indicate disseminated disease. You can see with in children in comparison to the adults, they can have more lymph node disease, especially cervical lymphadenitis, and very high chance of disseminated disease. And gradually, they develop the adult type of disease. This is the usual, the classical, the adult type of disease, mainly in after 8 to 9 years. But we don't see this adult type of disease. Can sometimes be seen very rarely, but less than 5 years of age. This is the natural history, how this trends are changing according to the age of the child. So, so what are the important differences in concern and when we compare with the adults? It's mainly postbacterial disease in children. That means fewer organisms, as well as they're having all of, obviously you know, children having less cough, and as well as this cough is less productive. So because of that, there's one important thing: they are less contiguous, but same time it's very difficult to catch the organism through sputum. So the rarely sputum become positive. So because of that, the microbiological diagnosis is little difficult. That is one of the main difficulties in diagnosis of TB or the confirmation of the diagnosis of TB in children. However, the TB is a microbiological disease, but mainly we are doing the clinical diagnosis. But the issue with the clinical diagnosis is it can lead into overdiagnosis as well as underdiagnosis. So because of that, the world is moving as much as possible. We have to at least try to get the microbiological confirmations, because it's very important in the long-term management, especially if a child does not respond into our routine treatment. So then diagnosis confirmation is very important, because there are many overlapping conditions in children. Other thing is, we have any disease, the clinical features are the most important thing for the diagnosis. Still, the clinical features are important, but the problem is there are many limitations in the diagnosis of TB in children, because the chest pain, like some chest symptoms or classic symptoms described in adults like night sweat, hemoptysis, sometimes a poor appetite is also not seen in children. But persistent cough, it is persistent more than 2 weeks. Documented failure thrice. So the weight gain is very important. Documented failure thrice. That is one of the key clinical features of TB in children. And fever or failure, fatigue and lethargy. These features would be helpful, but other features which consider as classic features are not helpful or not present in children very frequently. Other important thing is signs. We use signs for the diagnosis of diseases, but usually TB in children have minimal signs. And other thing is, usually they don't have significant respiratory distress. I'm sure you also encounter sometimes children present with significant pleural effusions, but going on for few weeks, but usually they are relatively asymptomatic in comparison to the children with pleural effusions due to bacterial infections. So that is one of the important differentiation. So they very rarely they have significant physical signs to diagnose or directly diagnose a condition. So because of that, it's very important to have high degree of suspicion. And other thing is this use of radiological, the chest X-rays in the diagnosis of TB adults. The classically they develop the classic the adult pulmonary disease, and usually chest X-ray itself diagnostic, and usually when they have this upper low predominance disease, cavitatory lesions, lot of organisms are there, and these organisms are entering into the bronchial tree, so they are shedding lot of organisms. So the diagnosis or confirmation, the suspect in the clinical and radiological diagnosis is very easy most of the time in adults, as well as confirmation with microbiological investigations also very easy in most of the time in adults. There are rare exceptions, but most of the time that is the reason. But children, they have variable intrathoracic involvement and no typical radiological features and overlapping with other conditions. So because of that, even with the radiology also, there might be significant limitations in diagnosis of TB in children. So what are the possibilities? They can have uncomplicated lymph node disease. I'm just giving a little bit idea about the intrathoracic manifestations of TB, the spectrum. Sometimes we might be able to see this enlarged lymph nodes, but this is not a common situations. But if these are there, if you see some abnormal perihilar region lesion, so the widening of the mediastinum, again suspect TB as well. And sometimes the primary point of infection, the bone's focus, might progress to and lead into the post-primary disease. Sometimes we see this type of lesions, but again, these are non-specific, can develop due to any other respiratory conditions in children. And if the enlarged lymph node obstruct the completely obstruct the bronchus, can lead into collapse of this lung, that affected side. Or sometimes these lymph nodes and erode into the bronchi and lead into bronchopneumonia. Sometimes you see this type of X-rays, but again, these are non-specific. And expansile pneumonia, the spread of the infection throughout the lobe can lead into lobar pneumonia, even TB, but commonly lobar pneumonia develop in children due to some other bacterial infections. So we cannot differentiate, but again, need high degree of suspicion in these cases. And the classic miliary disease, obviously, the miliary modeling, this is an important thing. Usually adults, there are so many differential diagnoses like microlithasis, and there are a lot of differential diagnoses for miliary TB in adults, but most of the time, children, it's almost always due to TB, except some herpes simplex infections, varicella infections, but it's rare, and most of the time it's due to TB. And they can develop pleural effusions. There are a lot of differential diagnoses for pleural effusions, TB also possibility, and pericardial effusions, you see this type of globular heart. But again, the confirmatory evidence are usually, it's very difficult to obtain through pleural effusions and the pericardial effusions. So microbiological diagnosis, always we encourage to have the microbiological diagnosis, but it's again difficult. One thing is difficulties in obtaining samples. So what are the samples that we are obtaining? Most of the time is respiratory or the lung involvement. We have to collect some respiratory sample. The classic sample is the specimen is sputum, but obviously children, difficult to obtain sputum. If they are older children and having productive cough, we would be able to get expectorated sputum sample, or we might have to do induced sputum. Nasopharyngeal aspirate is a possibility, but usually nasopharyngeal aspirate does not give a good sample. So usually we don't do NP for a diagnosis of TB. And the gastric aspirate, although this is not a respiratory sample, but if we want to get gastric or the catch the organisms in the lungs, gastric aspirate would be a better option. But if you are really want to get a microbiological diagnosis, the BAL, the bronchoscopy and the bronchial lavage is the best method of getting the sample. So we can have other samples or specimen depending on the involvement of the organ, maybe lymph node, biopsy or FNA, CSF, joint aspirates, tissue biopsies, bone marrow, even urine, if you suspect renal tuberculosis. So these are the samples or the specimens we have to catch or get to get the TB microbiological diagnosis. So what are the available tests? Microscopic or acid-fast bacilli, the classic thing, but again, the sensitivity is very low. I'll show some figures. Cultures, solid and liquid culture, still the gold standard, and the PCR-based techniques. So these are the most important diagnostic tools in diagnosing TB in children, these PCR-based methods. So why is challenge in the diagnosis of TB confirmatory or the microbiological diagnosis? Because the low sensitivity of these available tests. The sputum AFB, the seal-Nielsen or the acid-fast the staining for acid-fast bacilli, the smear. This is the main method of diagnosis of TB in adults. Around 75% of adults with the classic, the pulmonary TB, sputum is positive. But in significant contrast to that, children, it's about 10%. The gastric aspirate about 10%. Sputum obviously is less than 10% even. And the cultures, sputum culture, 90% of the time positive in adults. But again, that is also positive in less than 50% of instances. So that you can see the difference in the sensitivity of these tests, the diagnosis of, or the confirmatory diagnosis of TB in children in comparison to the adult population. Why is this? Because the number of bacilli, so to become to give a positive results in my AFB samples or the microscopy, there should be 5,000 to 10,000 colony forming units per milliliter, or the organisms per milliliter. So then you can see if the child might have the disease, but that child's sputum contain 1,000 organisms per milliliter. Obviously, we might not be able to catch the organisms with AFB. And solid culture need to have about 100 to 1,000 units. The liquid culture is the most sensitive method of catching the organisms or having the confirmatory diagnosis. But even though this is not the automated NAT, I'll come to that. That much sensitive, but this is very important when we compare with the timing of the diagnosis. So when we compare the sensitivity and the timing of the diagnosis, this is again from adult data. This is the percentage of when we consider liquid culture as the gold standard, and if we consider liquid culture as 100%, the the duration, as you know, culture will take time, but liquid culture with some enhanced techniques, with enhanced methods of culture, that means enriched media, we might be able to catch the organism or identify organism within 3 weeks. Sometimes, especially for non-tuberculous microbacteria, sometimes we get the positive results within 10 days. So that is one advantage, and its sensitivity. So GeneXpert is the other important thing, that is the very rapid. So within 2 hours, we can get the diagnosis, as well as its sensitivity also fairly high. The solid culture, classic solid culture, even though the sensitivity and specificity is high, it will take time, you know. It takes at least 6 weeks to give a negative sample. And microscopy, obviously 60% this is from adult data. It's rapid, we can get the positivity within 20 minutes, but the sensitivity is low. So you can get some idea what are the tests we can use, these advantages and disadvantages. So the PCR based techniques are the main tests that important for the diagnosis of the confirmation of the TB. The classic PCR is the one we used for a few decades. You know, in Sri Lanka also we have only few facilities to detect do the PCR. It's a complex process involving mainly 3 steps, and the denature, the annealing, and the extending state. And the classic PCR things, PCR laboratories, all these steps are done separately, and there's a high risk of contaminations and polymerization giving post-positive results, as well as they have to maintain highly standard laboratory conditions to conduct a PCR lab. So to overcome this method, the CBNAAT, the cartridge-based nucleic acid amplification test, the same test based on the PCR technique, but here, the most important thing is a cartridge-based systems. This was originally developed by the CFIT company, USA, and now WHO, almost decade now, WHO has endorsed this as the first-line diagnostic test for pulmonary TB, and especially, and even the extrapulmonary specimen, especially in children. So this is a fully automated system. Not only the diagnosis of TB, it can identify this RNA polymerase beta subunit. That is a part of a gene that is called the RPOB gene. So the mutation in this gene is responsible for development of rifampicin resistance. So we can identify the genotype possibility of giving the rifampicin resistant, and currently rifampicin resistant is considered as a possible surrogate marker of MDR TB, multidrug resistant TB. So with GeneXpert, we can identify the organism as well as the possible rifampicin resistant. So the GeneXpert means this machine. So this machine is the one and the cartridge, the one revolutionized the management or the identification of TB. This is a cartridge-based nucleic acid amplification test. GeneXpert and the cartridge are called the Expert MTB RIF is the one which we are using to identify TB. So the Ultra is available, and even there are cartridge developed to identify COVID-19. So various tests, various cartridges are developed. We can use the same machine. If we have the different cartridge, in Sri Lanka also COVID-19 cartridge were used to diagnose COVID-19. Actually, this test was initially developed to identify anthrax. You might remember there were a few years ago, there were some terrorist attacks in other countries, especially US. With anthrax, they send these anthrax powder containing anthrax bacillus through post or even as letters. So to identify anthrax very rapidly, initially they developed this system. Now it's mainly using to diagnose TB as well as COVID-19. And this has obviously revolutionized the identification of TB. So I'm not going to the details. It's important thing is just mix the sample into their solutions. Just after that, the sample get denatured. That means the infectivity get destroyed. Only this is the time which human encounter happen. And once you insert this sample into the cartridge, all the things happen automatically within the cartridge. It is a non-touch system. So the advantage is detect both Microbacterium TB and the rifampicin resistant, better sensitive in comparison to microscopy, and no need advanced biosafety equipment because it's automated systems happening in the closed cartridge and low risk of contamination. But that's also have some disadvantages. One thing is because it's just detect the DNA fragments or the genetic materials, no need to have the live organisms. Just the fragments of genetic material would be enough. So because of that, we cannot differentiate live and dead bacilli, and because of that, we cannot use this as a monitoring assess the treatment monitoring success of the monitoring, because even the treatment is successful, the dead bacilli might be there, the genetic materials might be there. Persistently, GeneXpert would be positive. So because of that, we don't do repeat GeneXpert to assess the success of the treatment progression. Other important thing is we cannot differentiate Mycobacterium tuberculosis from the bovis with that means the BCG with this GeneXpert technique. That is important. Still, we see then some children presenting with obvious clinical BCG adenitis, especially some surgeons also involved, taking aspirations and sending cultures and GeneXpert, both could be positive. Sri Lanka, we don't have currently system to differentiate even with cultures, the bovis and BCG. So the report automatically coming as positive for Mycobacterium tuberculosis, and unnecessary, these children end up with full course of anti-TB treatment. So because of that, if you are managing children with obvious clinical BCG adenitis, don't do aspirations, don't send samples for cultures or even GeneXpert. We cannot differentiate. So this is the currently available most advanced technique, the GeneXpert Alpha Ultra. Its higher sensitivity is higher. It contains more materials to detect, and the results can taken within 80 minutes. Another thing is a screening for latent TB. You know, we have two methods to identify the patient has sensitized with TB. MAN2 test and interferon gamma release assay. The quantiferon gold is the trade name. It's an in vitro assay. So both these tests give information only about this patient has infected with TB only. So we cannot differentiate active disease with the latent disease. So that is one drawback. So again, one important thing. Other thing is IGRA. Again, the limitation is it's not validated in children less than 5 years, and we cannot use in children less than 2 years. So the most significant proportion, most important proportions of children who develop the disease, IGRA test is not useful. That is another important challenge in diagnosis. So finally, so we have to follow this is the new guideline or the algorithm introduced by the TB campaign. We also involved in developing this. So according to that, the last slide, if we suspect TB clinically or radiologically, depending on the clinical symptoms, we have to get the samples, but the chest X-ray, obviously we have to do any child suspecting pulmonary TB, but the first line investigation is expert MTB refer, GeneXpert, and if the sample is sufficient, can send it to TB culture. So don't send pressure samples for AFP because there's no point of sending. GeneXpert 30 plus machines are available in Sri Lanka. Last few months there was a problem with getting down the cartridge, but now all are available. So the sample sent for MTB, the GeneXpert in Colombo area within 1 kilometer radius. We have 2 machines at Colombo Chest Clinic, 1 machine at LRS, and 1 machine at Colombo Medical Faculty, and 2 machines at NHS. So that is available. So make use of these test as well. So in summary, TB is still a challenging disease globally. Significant morbidity and mortality is still happening due to this disease, especially in children. Childhood TB has more challenges than adult TB. TB is a microbiological disease, so it's very important to have a confirmatory diagnosis, but it is still the confirmation is difficult in children. No classic symptoms and the signs are very less frequent in children. And because of that, very high degree of suspicion is important to prevent the missing the diagnosis. So children are dying unnecessarily without starting treatment. So obtaining a proper sample is difficult, but as much as possible, we have to try to get samples. And the CBNR, the GeneXpert, plays a major role in the diagnosis. So it is very important to follow the new algorithm for diagnosis for children. Use GeneXpert to overcome these challenges in the diagnosis. Thank you very much.